Hello, welcome to this webinar. It's actually the second global webinar that the Arthroscopy Association of North America has partnered with our Korean colleagues and the Korean Arthroscopy Society. In fact, it's one of our favorite global partners because of the huge contributions to science that our Korean partners do. So this should be a wonderful webinar talking about knee and shoulder. And some cutting-edge issues. I am Dr. Mark Hutchinson. I'm the chairman of the International Committee for the Arthroscopy Association of North America. And from AANA's side, we bring you two wonderful speakers, Kevin Bonner, who is the professor from Eastern Virginia Medical School. He's the director of the Jordan Research Foundation. He's been awarded many times top doctor. He's a former U.S. Navy chief of sports medicine where he took care of the Navy SEALs, and he's in the presidential line for AANA. Dr. Brian Waterman is the professor of orthopedic surgery at Wake Forest. He's the chief and fellowship director of sports and shoulder surgery there. He's the team physician at Wake Forest, USA Ski Board, and a farm team for the Chicago White Sox baseball team. He's had multiple honors, Meritorious Service Medal to the United States Army. He currently serves as the chairman of the Education Committee for the AANA and sits on the board of directors. My colleague, who's co-moderator, Professor Jay Yu, thank you so much for participating and having this collaboration with Korea. Would you like to introduce your colleagues?
Okay, thank you very much. I'm JC Yu from Korea. I've been AANA one of the members for a long time, and I was the previous Korean Shoulder Nerve Society president. I'd just like to briefly introduce Dr. Kim, who's from Chosun University. It's in the city of Gwangju, which is south west of the country, and it's one of most dynamic cities in our country. And he's been professor for 20 years in performing knee, mainly knee as a knee specialist in Korea. It's very common just to do a single joint as a specialist doing arthroscopy and arthroplasty. And he has been UPMC with Freddie Fu Fellowship, and he has published many papers, and he has been one of the top-notch surgeons and researchers in our society in arthroscopy. And I'd also like to introduce Dr. Joe. Funny thing is that he has an American name, so we kind of make fun of him as Chris. But he's Hyuncher. His Korean name is Hyuncher, but we call him Chris, and so Chris Joe. And his Dr. Joe is really a researcher. He has like a 20, or if I'm correct, maybe more than 20 research team doing a lot of basic research on many fields. And I was so amazed to see his researches done by his entire team. He's not only a researcher, but he's an excellent surgeon, performing in Seoul National University within Seoul in a branch hospital called Borame Hospital. And he's recently been very interested doing a muscle advancement, which you'll see today, his technique, which is becoming very popular in Asia. Anyway, it's a great honor to introduce these two surgeons.
Wonderful. So why don't we get started? What we're going to do here is, as we get started, if you have any questions, select either Dr. Yu or myself and type in your question, and we'll save those to a session. We're talking about the knee and the meniscus to start. Dr. Bonner will start, and then Dr. Kim will have our discussion, pick up any of your questions, and then we'll break into the more complex shoulder work and the cuff work. So without further ado, Kevin, you want to catch us up on the update of meniscus in 2025?
Sure. Thank you very much. And it's really an honor to be here with our friends and colleagues from South Korea. So thank you very much for the invitation. So I'll be speaking on meniscus repair, contemporary techniques, and my decision-making in 2025. So I have no disclosures relative to this talk. So we'll go over briefly the different repair options, all inside, inside out, outside in, and then briefly on root repair and then ramp repair as well. And as you can see from the diagram on the right, you really have different options based on the geographic location of the tear. And it does lend itself to surgeon preference, certainly. Typically, the anterior third is amenable to outside in, typically for me, and then the other locations can be a variable approach. So the all-inside repair, I personally tend to use this type of repair in about 65% of my cases. Here's an example on the right. And I think it's a very popular choice in the United States, at least, due to some clear advantages, including you don't really need an experienced assistant. So personally, I like to use this for smaller, less complex tears. Sometimes you can use it for a moderate sized tear, but this is an example on the right on a relatively small posterior medial tear. And you can see I'll typically use an implant on both implants on both the femoral side as well as the tibial side. And you can see vertical mattress stitches here. In my own practice, I'll typically use the all-inside approach when I have to use anywhere between 1 to, let's say, 4 to 5 fixators. If I need to use more than that, I tend to use an alternative approach. But for these smaller tears, I think this is often optimal. So these all-inside suture passing devices, this is something that we started using about 10 to 15 years ago. I think that where I find it very useful in my practice, I'm going to back up here, where I find it very useful in my practice is especially on the lateral side for some of these tears associated with ACL injuries, especially it doesn't make me quite as nervous in terms of the posterior lateral neurovascular structures. And it's very nice to place these circumferential compression stitches. And it can be used for various different tear patterns, but I think especially useful on tears such as this, horizontal cleavage tears, radial tears, and then certainly root tears. And so the all-inside meniscus repair, I think, is really my optimal choice typically for these smaller posterior tears where I need to use anywhere between 1 to 5 implants. These are not always easy. I would say to you that one thing that's changed my over the last 5 to 7 years is on the medial side, if you have a tight compartment, do not hesitate to recess your MCL and to pie crust your MCL. I think that's a very valuable technique that can make a very complex or difficult surgery in a tight compartment actually much easier. So the one thing, though, we are seeing, and these are all patients of mine anywhere between 4 to 7 years out, is that we're actually seeing new tears propagate from the insertion of these all-inside devices. I think very often you'll get a nice repair at time 0, but often the story is not over, especially with some of these all-inside devices. I caution you on over-tensioning to minimize the cheese wire effect, but that's what we are seeing in a fair number of cases is that, we walk out of the operating room giving ourselves high fives for a successful surgery, and then we see failures 4 to 5 to 10 years later. And I've certainly seen that in my practice. And the literature is really bearing that out now, that we're having higher failure rates, especially with larger tears on the medial side that are isolated, especially in the bucket handle situation. So I would caution you about using, implants or implants when you have to place, more than 5 or so on the medial side, especially because we tend to make Swiss cheese of the meniscus. The inside-out repair is certainly not always needed, but in my hands, it's often your best chance to perform an anatomic repair with the least damage to the meniscus. And it allows you to place multiple points of fixation with small needles. And in a larger tear, especially bucket tears, this is my procedure of choice. So here's another one, basically on the lateral side. You just have to be cognizant of your anatomy. This is a very safe approach. You just have to understand where you are and be cognizant of the neurovascular structures. And here we are placing both vertical mattress stitches on both the femoral side as well as the tibial side on both sides of the popliteus. And in my hands, for a bad tear, I can't perform a better repair than an inside-out repair, and again, with the least damage to the meniscus. Also, the inside-out repair allows you more mobility and basically the ability to place sutures and fixation in multiple locations, especially for these more complex tears, radial tears, segmental tears. And so in my mind, if you have a young athlete, especially with these large bad tears, and here's a young athlete, I think my procedure of choice is still an inside-out repair in this situation over an all-inside repair. Now, you do have to be proficient with other repair techniques. Basically, this is the outside-in technique. We used to use these mulberry knots and different types of techniques 25 years ago, but we really have more contemporary repair techniques for using outside-in devices. And I think that they're not nearly as common as the other techniques, but you do still have to be aware. As an example, here's a 20-year-old US football player where I did a hybrid repair. So I placed all inside devices posteriorly, and then you can see the tear really propagates all the way around anterolaterally. And I place outside in stitches to place vertical mattress stitches on both the femoral side as well as the tibial side. So again, not as common, but you still have to understand how to do it because it can be very, very valuable, especially for these anterior third tears. Now, root repairs, and I'm sure that our Korean colleagues are going to teach us a lot here as well, and I'm looking forward to hearing their tips and tricks. But we've evolved over time. I tend to use an approach where I'll use a transtibial tunnel, a very small tunnel, and basically I will place cinch stitches posteriorly. And sometimes you can place a single tunnel, sometimes dual tunnels. I'll often pie crust the MCL on the medial side, and there's some debate on whether or not you need centralization stitches or not. So here's just an example. I think it's very important to create a bone bed to reattach that meniscus, very similar to a rotator cuff repair. I've placed a transtibial tunnel, and then here I am with the cinch stitches. I'll tend to use tapes. And then I've gone away from using buttons on the anterior tibia. Due to some dissatisfaction, I'll use a knotless suture anchor at this point, and I've been much more satisfied with that. But here's the result of just a typical root repair in my hands. Here's another variant of a root repair is a 53-year-old physician. You can see it almost looks like a radial tear. And so in this setting, I will tend to come just more medial with my tunnel. I'll prepare the bone bed again. And what I'm doing is after I place my transtibial tunnel, I'll actually create a horizontal mattress stitch on both sides of the meniscus to bring that radial tear together. And then I'll also place cinch stitches as well. So again, just somewhat of a variant of a root type tear that's similar to a radial type tear. And I've been doing that more and more where I'll place a transosseous tunnel. Lateral root repairs, we'll see these with in combination with ACL tears. I'll typically make my tunnels for the ACL first, and then I'll make a separate posterior lateral tunnel for my lateral meniscus. I will fix the lateral meniscus first before I place my ACL graft because it allows for more optimal visualization, and I'll fix it on the front of the tibia. Ramp repairs. Basically, we're gonna hear from Professor Kim on his techniques. I look forward to seeing that. I'll place a posterior medial portal, and I use a 70-degree scope to look down. Here's an example. 30-degree scope looking at it. I'll switch to my 70-degree scope. I'll place that posterior medial portal. It tends to be more proximal than you think. We'll freshen up the edges, and then I'll use these suture passers. And I've really found in my practice, this gives me the most optimal result. As opposed to all inside techniques, which are still, you can certainly use all inside techniques for these tears. Just in my practice, I tend to prefer this technique using a posterior medial portal and suture passer. So I think it's important for all of us to develop a comprehensive armamentarium for fixing these meniscus tears. It's not, all repair techniques fit all types of tears. I think it's very, very important. Even if you use an all-inside technique for most of your repairs, which I do, very important to still know how to do a good inside-out repair, and then all inside, and then outside-in repair, and then using some of these suture passing devices, and then certainly utilizing the suture hooks that we're going to find out more from Dr. Kim. So I appreciate your time, and again, it's an honor to be here. Thank you very much.
Wow, amazing whirlwind. I mean, that covers a broad range of meniscus, and you're amazingly talented. And so I'm intrigued to learn some other pearls from Dr. Kim in terms of addressing some of those difficult to get to things posteriorly.
Thank you, Professor Hutchison. Hello, everyone. My name is Dong-hee Kim from Joseon University Hospital. It's a great honor to share our surgical technique for repairing the meniscal tear with suture hook and spinal needle. As you know, the meniscus treatment paradigm has shifted from resection to save the meniscus. The arthroscopy infographic accentuates three principles to get a good result after repairing the meniscus. A, anatomic reduction. B, biologic augmentation. C, circumferential compression. HC accentuate the importance of mechanical stability by grabbing the peripheral fiber as much as we can to enhance suture construct stability. To follow this principle, vertical matrix suture is better than a horizontal matrix suture. All inside technique using a suture hook are good for making a vertical matrix suture. As we know, inside out technique is standard and traditional technique for meniscal repair. This is 24 years male with bucket handle tear of right knee. After reducing the displaced fragment in place, the suture needle can be introduced from the capsular part first and pierce the meniscus next. And you can repeat this procedure and stabilize the up and down side of the meniscus each. You can see we can get a very good stabilization. But whenever you try to repair the meniscus using the inside-out technique, you should make an additional incision to protect the neurovascular injury, such as the saphenous nerve in the medial and the common peroneal nerve in the lateral. And the excellent assistant should exist to help you manage every process. And it is inherently difficult to make a vertical suture and anatomic repair when you try to repair the posterior horn because the condyle block the zone-specific cannula, making it difficult to create a vertical direction. Most of companies invent their own all-inside fixator to overcome this hurdle. It is usually composed of observable anchor and non-observable suture. Because this instrument is designed from the inside-out technique, this instrument makes it difficult to make a vertical suture and anatomic reduction and circumferential compression. And also it can be dislodged sometimes and irritated. So I will show you the suture-based repair technique. It is especially good for lamp lesion, and I always recommend two technical tips when the meniscus repair with suture hook is planned. First, make sure the suture hook pierces the full thickness of the meniscus. Second, for one knot stitch, making two separate sutures, inner loop and outer loop from the tear. Lamp lesion has a specific characteristic. The peripheral limb of the torn meniscus is almost always displaced inferiorly relatively to the mobile central fragment. The lamp lesion can be suspected from the anterior proving, and plastic cannula can be used. Whenever you use a suture hook to repair the meniscus, you need to make sure that the suture hook grabs the whole tissue. And I recommend two separate suturing to catch more tissue and anatomic coaptation. So you always have to make sure your suture hook grabs the full layer and grab it, and you can see it's quite stable. Sometimes in the loose meniscus, it is hard to pierce the meniscus with the suture hook. In this situation, the counter force with the retriever forceps can help you pass the suture easily. The retriever can count force from the inferior, and sometimes it can be from the superior. If it is difficult, you can use the retriever forceps to make a counter force. And this is a quite complex patient. As you can see, the meniscus has a flap and multiple longitudinal tear, deformed flap tear as well. And after removing the deformed meniscus, you can see the multiple longitudinal tear are observed. But patients still have preserved the peripheral circumferential fiber, so we can repair this meniscus with a suture hook. And also, we always have to make sure this suture hook can grab this circumferential fiber like a bundle of the starch. And also you don't need to repair too much, make a knot. And after repairing the posterior and move to the anterior, passing the suture hook in a horizontal complex tear, and PDS loaded spinal needle can be used as a outside-in technique, but the direction is vice versa. So superior string pulled from the inferior string pulled from the superior to make a circumferential compression. And dual ACL revision with hamstring tendon too. Fortunately, I can get a second gastroscope after 2.5 years later. As you can see, the graft looks very nice, and the meniscus has a good shape, and even it is quite small, but it's very good shape. And the PDS loaded spinal leader is good for repairing the peripheral tear in the posterior medial corner without skin incision. After penetrating the inferior spectra of the meniscus, then pull the one arm from the portal and withdraw it until outside the capsule, but still inside the skin without additional skin incision. And I can make a knot to repair the peripheral longitudinal tear. As you can see here, with a spinal needle, without any skin incision, just change the direction, and I can make a knot with a repair. And we can do a repair the lamp legend in the same principle. Repair the pull layer in one arm, and the other arm should be repair the pull layer. And make a knot, make a stitch. Okay. After repair the every meniscal tear, and the knot can be pushed from the capsular area. And from the previous outside-in technique, we invent a modified outside-in plus technique. PDS loaded spinal needle make a suture loop in the peripheral fragment, and the suture hook make the outer suture loop in the inner fragment. The vertical matrix knot is made inside the joint. This is the last video. As I explained, the bucket handle tear are often occurred from the red-white and red-red zone. In this situation, needed to preserve the meniscus, I tried to repair the meniscus with a modified outside-in technique in the anterior and the middle area without any skin incision. So after penetrating the meniscus in using a suture hook, and PDS loaded spinal needle can make an outer loop. Because of when you try to penetrate the meniscus in a thick area, it is quite difficult to using a suture hook, but spinal needle can be convenient than a suture hook to make an outer loop. And before you trim the meniscus, I always stabilize the meniscus. And especially close to the root area, you can pass the suture loop with the suture hook in a more easy way. But in the middle, from the root and the posterior medial corner is quite difficult area. But when you put the suture hook from the posterior medial corner, you can make a outer suture loop, and we can stabilize the meniscus tear. And this is the summary. If you are familiar with using a suture hook to repair the meniscus, your indication will be expanded. Thanks. Thanks for your kind attention.
Wonderful. I'm amazed at your hand surgical skills, getting all those sutures in all those different places. It's pretty impressive. So I'm not sure. I'm going to take one question we had from the audience to start, and then Dr. Yu, if you have a question to go. One of the questions was just to Kevin, and actually probably to Dr. Kim also, is what do you do with the kind of those degenerative horizontal tears? Are you fixing those also rather than the kind of the peripheral vertical ones? How do you, which technique do you like to use for that?
Sure, if you want, I can go first. So we have evolved toward trying to save more of those horizontal cleavage tears, especially in younger individuals. I mean, if I have an older person and it's very degenerative and it's a very small inferior leaf, I'll probably just do a debridement if it's somebody older. But we've certainly evolved towards trying to save more of these meniscus tears with the horizontal cleavage type of pattern. I will typically use the circumferential compression stitch, and in that situation, I'll use suture passers, typically in my practice, to place circumferential compression stitches, trying to save that horizontal cleavage tear.
Yeah, I also agree with Professor Bonner's idea. Especially even patient has a horizontal tear, it should not be the indication of the repair. But if patients are young and active, the horizontal tear is another candidate for the repair. But when I try to repair the horizontal tear, I always try to keep the suture construct in a peripheral part. As I show you in our video, I make a vertical suture first, then make a outside-in technique to grab all the horizontal tear, also including the peripheral blood supply.
Another question that kind of twists from the audience, and it was a question I had developed and was talking a little bit about the sutures. Kevin was worried about the cut-through sutures that we're learning from the all-inside devices or over-tightening. And then on the contrast, so we're worried about that cut-through. Now the question then is does the monofilament absorbable last long enough? Or does that also cause that cut risk? So just, defend your suture choices a little.
Professor Kim, go ahead. Take that one first.
Yeah, in Korea, for that reason, we prefer to use observable stripper than a non-observable material and non-observable suture as well. So as I show you, we always prefer to use a PDS. It will resolve within 6 months. But I think the 6 months is enough to heal the meniscus.
So the reason I typically use non-absorbable stitches, although to your point, Mark, it's very, very important to not over-tension those sutures because you will create a cheese wire effect and you'll have failures on a delayed basis later on, even years later. The reason, however, my choice is non-absorbable is that if you look back at the studies back into the 1970s and 80s when we were first starting to do meniscus repair, a lot of studies looked at both the clinical success rate versus anatomic success rates. And the difference is that when they rescope patients, a lot of these meniscus tears do not always heal anatomically. You don't get biologic healing, but you get clinical success. And the clinical success is often due to the fact that the non-absorbable stitches will still keep the meniscus reduced and keep it relatively stable. So in some of the studies dating back into the 70s and 80s, some of the non-absorbable sutures had a higher clinical success rate than absorbable stitches. So that's why I personally tend to still use non-absorbable, although I will still on occasion use absorbable PDS. And there's nothing wrong with either one. I think you can certainly make a good argument either way, but personally, that's why I tend to use the non-absorbable.
Dr. Yu.
Okay, just ongoing question to Kevin is that if you don't have knots, maybe that's kind of more rational. But like in a banker repair in shoulder, there's like a debate between knot versus knotless, where it's not weight-bearing joint.
Mm-hmm.
But your ramp lesion all suture repair with non-absorbable, that knot's going to be there for a long time in a very young patient with weight-bearing. So did that kind of worry you with the cartilage? Because I saw some banker patients with the cartilage wearing out. So do you kind of worry that?
It's a great question, and I do worry about that. Basically, I've never seen an issue with a ramp repair with those knots causing an issue, although maybe it's seeing us and I'm not just seeing it. But where I was really concerned, and quite honestly, why I was really hesitant even 8 or 10 years ago, was with the circumferential compression stitches on the meniscus, with the knots actually being more on the surface of the meniscus. I was actually very concerned about that. But when you look at a lot of repeat scopes where you go back in and look, it tends to get synovialized, and it's not been a big issue. But that's a great point. I was very concerned about that. I was actually hesitant to do it for a while. But when you look at repeat scopes so far, I have yet, and maybe you have seen some cases, I have yet to see a case where you get that chondral damage with intra-articular knots like we see in Bankart repairs sometimes. So I've not seen that. And we did see that back 25 years ago with like the bionic arrows. That was a big concern. But I have not seen it. Maybe some of the other panel has seen it, but I have not seen it. But it's a great question. I was very concerned about that as well, when I started doing that even 10 years ago.
Well, thanks, guys. I've learned a lot of great new pearls and tips on my meniscus. Dr. Yu, do you want to transition us to shoulder with Dr. Waterman and Dr. Joe?
So Dr. Waterman, please, can you start?
Again, many thanks to our colleagues for this opportunity and this exchange. This is incredibly meaningful, and I realize that many of these ideas have really sprung forth from our Asian colleagues. And I must admit, my disclosure is I'm a recovering biceps killer. The remaining of my disclosures are not as relevant to the content of this talk. I think historically, we've often considered sources of anterior shoulder pain, and I think we've often conflated these as being largely bicipital in nature. But as you can see, there's a wide variety of structures that can contribute to shoulder pain. And we'll go ahead and mute these, I'm sorry. There is a dense innervation. There are some intra-substance changes, but really rare histological inflammation. So really, it's more related to the way the biceps interacts with the tissue around it. And you can see a wide variety of biceps labral pathology, both from primary disease, as with rotator cuff tears, as well as instability with subluxation of pulley lesions, dislocation with subscapularis tears, and then the wide variety of slap lesions that we often see in our overhead athletes. And really, this is the spectrum of disease from lip sticking on the top left now to really macroscopic tearing and instability on the bottom right. But as we know, it often is the way it interacts with the tissues around it that defines the presence of bicipital tendonitis. And this is really our entry point into the discussion about whether the long head of the biceps tendon is truly a liability as a pain-generating structure, or could it potentially be repurposed as a precious resource? And really, I remember early on in my career looking at some of the early studies from Dr. Ree and colleagues, and they showed really utilizing the bicipital tendon to augment our repair. And that was really a revelatory moment for me because it reduces undue tension on the rotator cuff tendon. It allows for tissue augmentation. In their study, it measurably reduced re-tear rates and created comparable outcomes with or without the biceps involvement. And I think there's improved mechanical strength relative to traditional techniques. And as we know, really the rates of failure are quite significant. And our concern is that we need to get this right on the first time and not have to defer to some of these failures that come back. Because when they do come back, obviously the stakes get higher. The alternatives get much more expensive, whether you're doing tendon transfer, dermal graft, or other fasciolata, reverse total shoulder arthroplasty. And so really looking at the way that we might harness the local biology to improve our mechanical constructs as well as our healing. And you can see these 6 applications shown here where we talk about intertendinous augmentation, anterior cable work, as well as using an autograft patch, especially in those resource-limited environments. And so for me, it's been trying to repress my inner instincts and preserve this long head of the biceps or repurpose it. And we'll talk about the bicep smash, anterior cable reconstruction, and bicep centralization. First, with the bicep smash or onlay augmentation, this is really an excellent application. And much of this has been ushered in by our good friend and colleague, JT Tokish, who shows us that in this technique, you can use 2.7 centimeters of transected biceps tendon after biceps tenodesis. And you can ultimately place this in the smasher. You can take this back as an onlay, and it can achieve excellent mechanical stability and incorporate it in with the repair. Why would you consider that? Well, it's really a viable tissue augment. It enhances tenocyte proliferation, and it has better biomechanical load sharing properties. What about rotator cuff cable reconstruction? Well, I initially learned about this from Patrick Denard, but again, this is another technology that has sprung forth from our Asian colleagues. And you can see his application as shown here in an editorial or edition that we had edited. looking at individuals that are under 70, those Hamatos 1 and 2, those with supraspinatus and or infraspinatus involvement with cable disruption, absence of glenohumeral arthritis, and sufficient bone quality. And if you were to do a full reconstruction for an irreparable tear, you can use a free graft or a longer version of the biceps autograft. This is a case of mine. You can see this can be done variably with detaching the biceps or leaving it intact and rerouting it, so to speak. You can see the intra-articular view in the beach chair position on the left, and on the right, we're going to go ahead and debride this lateral sidewall. There's often some petechial bleeding, so we'll make sure to achieve meticulous hemostasis here. But really, we need to enhance the mobility so we can lateralize and centralize that biceps, and you can see as shown here. Oftentimes, then we're going to assist with incorporating in with the repair. You can see that anterior cable is disrupted. We know the important biomechanical principles that contribute to these tears. And so we will use these varying constructs in order to bring the two layers together to have that be a suitable strut and bring that residual anterior supraspinatus back, and then as well just doing some margin convergence sutures to kind of tubularize that anterior cable. And this is what it looks like at the end. You can see we've debrided the rotator interval. We can have our nice fine-tuned anterior cable reconstruction. And this 70-year-old lady with a strong interest in equestrian and fox hunting, you can see we can get her back to full activity in 6 months. You can see with anterior cable reconstructions for those largely more irreparable tears, you can reconstruct the anterior and posterior cable, again, achieving some level of humeral head depression and a static restraint to superior migration. Lastly, the technique we talk about is what we've often called centralization or biceps transposition. Others have called this biceps SCR. And you can see this is often for those individuals that have more of these functionally irreparable cuff tears. So the ones that definitely can be restored to the footprint, but under tension or they have more complex margins. This is a case of mine. You can see, again, a very large tear with disruption of the cable. You can see we're doing all the appropriate mobilization techniques, removing the bursa, but attenuated and delaminated tissue, definitely under tension. And so this is one where Larry Field has informed a lot of my thought process on this, where you leave the biceps intact distally, mobilize it, reroute it, centralize it, and then repair those residual leaflets. You can see in these high Hamada cases, he was able to achieve vast reduction in VAS pain score, also improving their forward flexion by upwards of 30 degrees. This is my case. You can see very limited subacromial changes. You can see in the MRI, this suggests a high degree of retraction with inflammation without some significant fatty changes. And so you can see in this case, we're going to start by placing some of these margin convergence sutures. We're going to centralize this with a suture anchor. And then ultimately, we're going to incorporate in that biceps tendon as shown here. You can see we're passing sutures in the posterior and anterior leaflet. We're going to centralize this. You can use this suture hook or this antegrade passer in order to have that be performed, and knot tying and traditional construct as resumed. You can see we achieve reasonable humeral head coverage as shown here. And based on our availability and our concerns about making sure we augment this relatively short tendon, in this case, used a dermal allograft for additional tissue augmentation along with biologics. So these are our final images, and this is our clinical result, which you can see, I think, is quite acceptable. Time will tell whether this continues to be equivalent to some of the other technology. So I'd submit to you that certainly the biceps is an excellent resource, both for structural and biologic purposes. And I encourage you to look at ways that we can augment or reroute the biceps. I think my indications tend to be for those cable injuries, poor tissue quality, short tendon, partial repairs, my surgery center location where cost is much more of a concern, and certainly leaning on that Rohe score for where an augmentation might be undertaken. We need to pay careful attention to the bicipital pain and potential for re-tears, as well as looking at overall value so that we can achieve an excellent result. Thank you.
Okay, Brian, thank you for the wonderful lecture. Let's have some questions.
Why don't we go? No, we'll do both
go
of the
second one?
cups.
Okay,
Yeah, so
okay.
let Joe speak, Dr. Joe speak, and then we'll
Okay.
do our
All right.
complex cup discussion.
Okay, Professor Joe, can you start?
Okay, good evening, Korea, and good morning in the States. My name is Chris Cho, Seoul National University. Today I'll present a integrated supraspinatus advancement for retracted irreducible rotative tears. We call it ASA, or arthroscopic supraspinatus advancement is an arthroscopic adaptation of muscle advancement that we developed in 2022 for using for specially designed elevators. The original technique was introduced by Dubier and Batte in 1965 with chromium osteotomy, and in 1981, the Haeri modified it with acromioclavicle joint resection. So in 2018, Moriara described an arthroscopically assisted procedure with a 4-centimeter medial incision, and the ASA is the latest step of fully arthroscopic technique without medial incision. Since 1965, approximately 14 studies of muscle advancement has been published, and one per decade until 2010, 2 in 2010s, and 9 in 2020s. And most of these reports originate from Korea, Japan, and Australia in the Asia-Pacific region. ASA is a stepwise 3-compartment elevation technique that advances the supraspinatus muscle over 3 centimeters, enabling maximum coverage of the greater tuberosity. A long ASA elevator is introduced through the lateral portal and guided by the superior glenoid labrum over the suprascapular nerve, and it is landed to the supraspinatus fossa about 5 centimeter medial to the glenoid labrum. And the muscle is elevated from the fossa, and the deep fascia is elevated, released medially, anteriorly, and posteriorly, allowing 3 to 5 centimeter lateral excursion without nerve injury. Today, we have reported 3 studies on the ASA, a technical note in 2023 and case series in 2025, and a retrospective core study, which is currently under review. So my indication for ASA is quite straightforward. Insufficient excursion of the lateral torn end and the active lifestyle in the patient. The contraindication includes severe osteoarthritis or cuff arthropathy, poor compliance, or possibly poor muscle quality observed in the chair view. However, I do not consider age, chair size, or retraction and pseudoparalysis, or less severe osteoarthritis, cuff arthropathy, or subscapular tears as contraindications. For indication and surgical planning of ASA, several updates should be noted. The first, the retraction is classified into 6 degrees from 1 to 6. The second, the excursion is classified into 8 degrees from A to H. And evaluating muscle quality for ASA, we do not rely on Y view. Instead, we use the chair view, which is located 3 to 5 centimeter medial to the Y view, because this part becomes critical after performing ASA. Okay, let's see how the ASA is performed. This is a right shoulder with a retracted irreducible tear. The torn end is located slightly medial to the superior labrum, and the lateral traction does not allow for a meaningful reduction. The retraction grade is 5, and the excursion grade is F. The procedure begins with superior capsulotomy with scissors, followed by the release of the coracohumeral ligament from the coracoid base. Next, a second straight elevator is used to superior release over the muscle, and then a downward elevator for the middle elevation of the fossa and the medial border of the scapula. And for posterior elevation, in this right shoulder cases, a right curved elevator is used. And finally, anterior elevation with using a left curved elevator is carried out for releasing the medial from the medial border and superior pole of the scapula. So after completing these steps, the excursion is reassessed. In this case, the torn end was advanced to reach the ridge of the greater tuberosity, and this is a final view. For this patient, prior to ASA, the torn end was nearly fixed to the labrum, but following the procedure, it could be mobilized laterally to sufficiently cover the greater tuberosity. During the elevation procedure, the medial border of the scapula may come into view. It's like this, allowing the surgeon to proceed under direct vision. So this is the medial border of the scapula. So this here is the superior pole. You can see the elevator to detach the deep fascia from the superior pole. And similarly, ISA, this is antegrade infraspinatus advancements can also be performed entirely arthroscopically. In this procedure, the medial border of the infraspinatus fossa can be identified. And the same principle can be applied to the subscapularis. However, this procedure is technically more demanding because the subscapularis muscle is considerably larger than the others. So we are still working on this technique. So here are additional cases in which the ASA procedure was applied. As shown, the most of retracted irreducible tears with excursion grade E or F can be converted to the at least grade B after ASA, and in turn, which resulted in much better coverage of the greater tuberosity during repair. So in our cases, 94% of the excursion grade D tears were converted to grade A or B after with ASA, compared to only 35% without ASA. One of major concerns with ASA might be the risk of suprascapular nerve injury. We carefully evaluate these issues and followed up our patients closely. To date, none have shown clinical symptoms of signs of nerve injury. So on the contrary, the most remarkable improvement observed after ASA was the rapid and steep reduction of preoperative pain. Furthermore, MRI at post-operative 1 year revealed no evidence of suprascapular nerve injury in either the supraspinatus or infraspinatus in more than 100 patients. This is a 66-year-old male with a retracted irreducible tear in his right shoulder. He initially presented with a pseudoparalysis in both flexion and abduction. And after 6 months post-operatively, he was able to raise in both coronal and sagittal planes. And these are the representative pre and post-op MRIs without his re-tear and with ASA. So since 2020, 7 studies using studies reported the re-tear rate after a muscle advancement have been published. The reported re-tear rate around 10 to 15 in irreducible tears, which highlights the significant value of the muscle advancement in treating these challenging rotator cuff tears. It's a quick talk. Thank you for attention.
Thank you so much, Chris. That was wonderful. I do remember some studies from, I think it was a hospital special surgery that showed some risks of over retraction and then getting nerve injuries to the suprascapular nerve because of over retraction or over tensioning. Have you seen that at all?
No, fortunately. But in the most of the kind of studies are doing on the cadaver, which have a formalin, is fixed with the formalin. You know, there's quite more than 10 studies back to 1960s, 70s, and 80s. You know that with the formalin fixed, the cadaver tissues have less elastic, about 10 to 15%. So, in most of that studies concerns about the more than 3 centimeters or even around 3 centimeters of lateral excursion due the initial due to the suprascapular nerve traction injuries or injury or avulsion injury from the muscle. But I know that this was the one of the reasons why we do not report or carefully follow the more than 1 years in all the patients had a MRI post-op. So and none of the patient has any nerve injuries in the MRIs, and clinically, yeah.
Good. So no de-innervations of the muscle or anything like that. So excellent. We have a time for maybe a couple more questions, and one
Yeah,
from
I have one
from the audience was questioning whether you're doing these fairly aggressive releases, and you can't put a tourniquet around this area. So how do you control the bleeding in visualization as you're doing some of those more aggressive medial releases?
In this procedure, you elevate the muscle from the bone, and usually in the superior osteoly, and that makes less bleeding. So and we do not use the very low pump pressure, around 50 to 55 millimeter mercury. And one of the reason might be we use epinephrine for bleeding control. Anyway, this is not a big blood surgery.
Good. Dr. Yu.
I have like 2 quick questions regarding your repair and retail rate. All the repair has a retail rates, but it seems that your study doesn't show this. So how do you manage not to have retail rates in a rotator cuff repair? And secondly, is your subscap muscle advancement, there is a risk of injury towards the lung, but with one or two surgeons that I heard had punctured the lung and had a pneumothorax. So would that be a risk for a subscap muscle advancement?
And the second question first is this is why I said we are still working on this technique. Puncturing to the lung, you should be careful, and you use the ruler on the elevators, and you can prevent that kind of serious injuries. And the retail rate we have around, I said 13, is more than 10% still. So I don't think that could be managed with the kind of mechanical surgical technique. I think that's the reason for biological augmentation or biological strategies.
Okay, thank you. So, Dr. Hutchison, do we?
Sure, Brian. There's a question about when you're doing the cables. Do you actually remove the rotator cuff interval tissue when you're doing that cable construct? And what's your main indication to add the cable? What tear patterns do you most commonly apply it to?
Yeah, the first question is regarding the rotator interval. I'll often leave that comma tissue because I think that's the load sharing tissue that I like to preserve. But I will excavate that rotator interval more medial and remove some of the coracohumeral ligament just so I mostly can appreciate the subscapularis pathology. For the anterior cable, it's truly those ones that are almost that L-shaped tear where there's disruption of the cable and it looks either attenuated, almost those attritional, poorly vascular tears, or those where the tissue appears attenuated. Additionally, again, working off the Rohe score, I think those with advanced age, those with revision tears, and then particularly delamination are among my considerations.
So Brian, and actually a little bit for Dr. Joe. I know we're not seeing your talk yet, but it's going to be you're doing complex things. And my question is I'm a good arthroscopist. I'm a basic shoulder arthroscopist. I can do instability. I can do a basic cuff. When do I start doing this stuff? This is pretty advanced stuff. What's the learning curve? How do I get to your skill level? Brian and Dr. Joe.
Dr. Joe, do you want to take that first?
I take first. I'm usually do about 400 arthroscopy rotator cuff repairs a year for more than 15 years, maybe. Right now, recently, of 4 or 5 years, there are some government and medical student issues. So the number. So I think the number will be very important. And still, I'm learning. Every day, I'm still learning. So you are so humble to say that, but and number is very important. And the second one is the philosophy and the making the goal. So what is the goal of the surgery? So to be clear, to have the clear goal of the surgery, you can improve any skills and I can obtain the good results, I think. So for me, the goal of the repair is to get a maximum coverage of the greater tuberosity after repair. So for that, I do the this kind of release and this is one of the reasons why I do the muscle advancement for repair.
I like hearing what you're saying, and that is to as for somebody who's progressing along this educational pathway, stick with fundamentals, stick with the philosophy of what you're trying to accomplish, and then start adding the skills that get you there. And then I guess sometimes if it's too complex, send it on to great people like you and Brian. Brian, your pearls of how should people advance on this skill set?
Yeah, for me, the starting point was a dovetail into an arthroscopic suprapectoral tenodesis. Initially, I was somewhat uncomfortable with identifying those structures, and so if you wanted to, you could tag the biceps and follow it down into the groove. And for me, then it was really very limited steps forward just to centralize it or start looking at some of these transposition procedures. I think getting comfortable with the lateral viewing portal is also key, utilizing, as was mentioned, 70-degree scope or variable scope angles. But probably the biggest take-home point that has been the game changer for me is don't indiscriminately sacrifice the biceps, because it can be an important resource. And that's been, again, the biggest shift in my practice over the past year or so, based on largely the work from Korea, truthfully.
So really the fundamental there is respecting anatomy. Dr. Yu?
Yes.
Okay, Brian, I'm just curious. So the biceps, what we call biceps SCR or rerouting procedure has been very popular in Asia, especially in Korea and China, maybe. But then, it kind of wear, it's like an SCR, which is had a big boom on it, and then it kind of wear down. Biceps rerouting or SCR is somewhat going to the same path. So there is a believer versus non-believer in this procedure. So I'm sure you're one of the believers, but what you think in USA that with this technique, I mean, if there is a biceps, that is, many of them don't have a good biceps. Let's rule out that patient. But if it has a relatively good biceps, what's the percentage that doing, I believe that this works in anterior cable reconstruction, doing a biceps SCR in USA versus, I don't believe in that. I'll just do something else.
It's funny you mentioned that. You're talking about trends in Asia, and much like many things, we're 10 years behind you. So you've led the charge, and we're learning on your experience. The adoption curve is very early in North America, and I would say that we're trying to better define indications. But the biggest issue you discuss, and I think needs to be discussed, is that of value, financial cost. Because dermal grafts, as we know, are very expensive. They're not routinely available in the international community. And so as we look at ways that we can reinforce our repairs, I think we need to try to find more cost-effective options. Synthetics, bioinductive patches, they all reduce your bottom line, and they may not be feasible for all patients. And so that's really what's driven my interest in the biceps as an augmentation. tissue reinforcement as well as humeral head coverage, as we discussed. Those are really my core principles. I'm curious your thoughts.
Yeah, I think that's a very important point. I think if like some of the allografts or Regenetin, all these things are very expensive, and I think using a biceps for different ways, I think would be very economical and very efficient in terms of that. So I kind of agree with you. In Korea, right now, human dermal allograft is not as expensive. I don't know, as rest of the world maybe. So it's a very popular option that you show you are augmenting for that difficult case.
Well,
Anyway,
maybe you can link me up with your tissue provider. We'll talk offline.
Okay. All right, that sounds good.
And as we move forward, we want to thank this wonderful cohort of speakers, Dr. Joe, Dr. Bonner, Dr. Kim, and of course, Dr. Waterman. You've done an amazing job of getting us up to date on knowledge. I particularly love this collaboration with Hands Across the Water, Hands Across the Pacific between Korea and the Arthroscopy Association of North America. It's an enormous, wonderful collaboration. We know that from the contributions from Korea to the journal, the cutting edge science that you guys do, and we learn from each other. And regarding that continued learning, here you can see on your slide several different opportunities for continued learning beyond what you just had today. AANA has learning skills lab courses. There's ortho skills training online, all available on our website. Similar for the Korean Arthroscopy Association. Hit the websites and look for all kinds of new opportunities. Dr. Yu, thank you for co-moderating this. I think it's been amazing, and I look forward to next year's webinar and more live interactions as we share each other's knowledge at meetings and such. Dr. Yu?
Okay, since when I was a fellow, my first any international meeting was AANA in Washington, D.C. in 2002. So I think AANA has been, our Arthroscopy Society of North America has been one of the most leading and teaching thing. And I think we're all grateful as a Korean, and I think that helped us to build up to such a caliber right now within our society. So we're grateful, and hopefully we can collaborate each other on many more years and for a long time. Thank you very much for the great seminar.
Thank you, everybody, and thank you, the audience, for your attention. Thank you to these great speakers. We appreciate it. Have a great day.